Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right, guys. So I welcome one and all for the class today, and we have a class on diabetes in pregnancy. Actually, it should be a broader term. It should be called as diabetes in pregnancy because we'll be dealing not only with the gestational diabetes, we'll also be touching upon diabetes type 1, type 2 in pregnancy. Those patients, of course, you get very less, but nevertheless, this is a very important aspect of dealing with diabetes. And whenever the exam is going to come, examination or viva is going to come to you, they might touch upon these aspects. Of course, if they get more time from the GDM itself. So I welcome Lavanya today to take up the class on GDM and take us through her case presentation. Welcome, Lavanya, and we start the class.
Yes, ma'am. Good evening, ma'am. So my patient, Mrs. X, wife of Mr. Y, 30 years age, and she's resident of Delhi, educated till 5th class, housewife by occupation. She belongs to lower middle class family by modified Kukuswami scale, and her LMP last menstrual period is 6th of December 2023, and expected date of delivery is 13th of September 2024 by her LMP. And she is having her regular menstrual cycles, and period of gestation is 37 weeks 6 days, and obstetric score is gravida 2 abortion 1.
Okay. Go on.
Gravida to abortion 1 with 37 weeks 6 days period of gestation for her LMP, came with complaint of pain abdomen since 5 to 6 hours.
Okay.
History of presenting complaint. Patient came with complaint of lower abdominal pain since 5 to 6 hours. So pain in lower abdomen radiating to her back and mid thighs, which is intermittent in nature with mild intensity. There is no aggravating or relieving factors for the pain. There is no history of bleeding per vaginum or leaking per vaginum. No history of vaginal white discharge or foul smelling discharge. No history of bowel and bladder complaints. No history of any infection, and she is perceiving her fetal movements well.
Okay, so guys, I think by now you know that why have you taken all these histories? Though this should be a direct question, why have you taken this kind of history? But we have gone over this so many times that by now you know that we're just trying to differentiate this pain of whatever she's come to us, that it is a labor pain or is it emanating from some other secondary causes. All right, so this is why she's asked all these things. So it looks like that it's a labor pain because of all the important observations and all the DDs that we are talking about, like whether she's got any vaginal discharge, whether that is one reason causing a preterm pain or some pain because of some other, resident or overt bowel problems or bladder problems. So, which is not, and we have delineated to a great extent. We now know it looks like the DD is mostly falling in favor of a labor pain. So, anything specific that you want to tell us about first trimester? Because it's a long case, we have to discuss a lot. So that's what I'm asking you. Let's be short here. Anything important in
Yes,
first
ma'am.
trimester?
So in her first trimester, first of all she's a it is a spontaneous conception, and ultrasound done around 2 months to confirm live intrauterine pregnancy, which is more important for our dating. And in she underwent, ma'am, like she's a booked
All
case.
antenatal investigations were normal. This is what you want to say?
Normal.
Yeah,
Yes, ma'am.
all. Okay, all right. Okay,
And
this is also
she
first
under
trimester. Okay,
yes,
nothing
yes,
eventful.
yes. So
Okay.
here we have to note that in she underwent oral glucose test in her
Hmm.
booking visit, and it is normal as per the patient.
Okay. So, though I would have asked you when you would have given me a leading answer or a leading, reason to ask you this question, you never mentioned anything about it, and there was, and even if you do get an examination, such a thing, please don't mention it in the first trimester. Let the examiner ask you. But yes, since you have already told me this thing, you've written this down, oral GGT. Why did you do OGGT in your patient in the first trimester?
Yes, ma'am. So there is a DIPSIC criteria, diabetes and pregnancy study group criteria, which we follow in our India, in our nation. So in which it says that during her first visit only, so we have to perform this oral glucose tolerance test by giving 75 grams of glucose. So
So we have something
that
written
is
over here. Actually, Indians, Indians, Asian population, they belong to the high risk category. So they say that any such population which has couple of these high risk factors, you have to get them for a screening test. Now, RCOG guidelines are different. Your Indian guidelines, especially that of MOHFW, they are different. Obviously, the National Diabetes Data Group, they are different. So you have a lot of guidelines, and I don't want to confuse you. So we have got for you mostly our entire Viva and our entire this what do I say management will be based upon the Indian guidelines. Yes, Lavanya. So where have we got this maximum data from? Just share that.
Yes, ma'am. Yes, ma'am. National guidelines.
So we are going by the national guidelines. In fact, all of you had asked me to give you a breakup of the calories and everything. So that also we have beautiful charts are given in the national guidelines, but it's too big a guideline. It's how many pages? 80 pages plus. But you don't have to
Yes.
study everything from that guideline. There's certain important tables, certain important charts, certain important algorithms that we have got for you, and just this much. If you do for diabetes, you are done. All right. Nobody is going to question you more. Nobody is going to question you less. They will expect this much from you. They will see in other guidelines. Whenever I was talking to you about other, topics, I told you stick to one guideline. Okay, otherwise you'll get confused. But in diabetes, if you do not mention the other guidelines, if you say I've studied only from RCOG, I've studied only from ACOG, and I don't know anything about Indian guidelines, that's not taken nicely. The same way about HIV. So in HIV, you don't get so many cases. First of all, I don't know how many of you have ever got a case of HIV, but HIV case not very much, but you have NACO guidelines in it. So that is one gray aspect that you need to know the national guidelines as well. But as far as you have this particular group is concerned, the diabetes and pregnancy group is concerned, you have these are the different varieties of groups which are working on this particular thing, on this aspect, and they have their own set criteria. It's not important for you to learn all of them, but you should know that they are also there, specifically when it comes to screening. So let's just finish off as much as we can from here. Tell me about the low risk and high risk, and then we'll take you to this chart. Yes. So why did we do a screening in the first place of this patient at 20 at booking visit? Yes.
So, mostly in our Asian population, so many people, pregnant females are more prone for gestational diabetes. So we belongs to high risk population, and these are categories depending on risk factors. If it is low risk, belongs to age less than 25 years, normal pre-pregnancy body weight, and no history of diabetes in first degree relatives, and no history of abnormal glucose metabolism or no history of poor obstetric outcome. In high risk category, these people include age more than 30 years with obesity and family history of type 2 diabetes in first degree relative like mother, father, sister, and previous history of gestational diabetes and past history of bad obstetric outcome and persistent glycosuria. So these are all high risk group in which we have to do the screening in the first visit itself.
Okay. So in our patient, Lavanya, what high risk factor did we have? We have just started the case. That's why I don't know the entire risk factors in here. So let me know what high risk factors did we have that we screened her as soon as possible in the first trimester.
So in my case, she belongs to overweight, ma'am, and age is more than 30 years. And as
First degree
she
relative
is
also she has, I think, right? Her mother is
yes,
diabetic or
ma'am,
father
first
is diabetic?
degree. Yes, ma'am, first degree relative. Mother is also type 2 diabetes. And
Hmm.
as she is in Asian population, so
Yeah.
I'd like to screen her in
Ethnic
first.
ethnic group is also. What is her age? She's 30 years. All right. What
30.
and weight
Yes.
we don't. I mean, right now I don't know the weight, but according to Lavanya, she says that she is her weight is in the higher category. She's
Yes.
obese according to your
Hmm.
examination, and she also has a family history of type 2 diabetes in the first degree relative, which is why you've taken this particular thing that you have to do it as soon as feasible, the screening for GDM, and then you have to repeat it at 24 and 28 weeks. All right, let's first take up the OGTT here. Let's finish this also. Yeah, tell me now, what exactly do you mean by OGTT? What is to be done? How is to be done? What are the values in which you have to be alert? And when do you club her as a GDM?
So, coming to screening test, ma'am, there are many guidelines to follow, and there are one-step and two-step methods. So,
Hmm.
two-step method is followed by ACOG. So, in
Hmm.
which there is GCT and GTT, glucose challenge test and glucose tolerance test.
Hmm.
Glucose challenge test is done by 50 grams of glucose. So in this we take fasting and postprandial. According to values, we can will label them as a gestational diabetes or in the risk factor to develop gestational diabetes. So in the group which belongs to risk of diabetes, we'll screen them again. We'll ask them to undergo glucose tolerance test, which is second step, which is diagnostic step, with 100 grams of glucose. And again, we'll take 4 readings, fasting 1 hour, 2 hour, and 3 hours test. And if there is more than equal to 2 values or abnormal, we label them as gestational diabetes mellitus according to ACOG. Which is two-step method, and remaining all are one-step methods in which WHO, IADPSG, and DIPSI also comes under one-step method. In our guidelines, our national guidelines follow this DIPSI, diabetes in pregnancy study group in India. So we follow the 75 grams of one-step method. On the booking visit, on first visit, we'll ask them to undergo this DIPSI with 75 grams of glucose. And then if it is less than 140, then we'll ask them to again screen in the between 24 to 28 weeks. If it is more than 140 milligram per deciliter, more than or equal to, then we label them as the gestational diabetes mellitus, and we ask them to uh, further follow up and treatment, and we'll explain them, ma'am, further.
All right. So you mean to say that your patient in the first trimester, when you did her OGGT, according to this DIPSI value, which you have to just take one sample at 2 hours
Reading.
after giving her 75 grams of glucose, and you don't take a fasting sugar. That means if her sugar at that time was less than 140. This is what you want to say?
Yes, ma'am.
All right. So in that case, you'll have to, would you repeat it still at 24, 28 weeks? That was fine.
Yes, ma'am. Since she's under less than 140 milligram per deciliter, I want to repeat her again, DIPSI around 24 to 28 weeks.
Okay. So we are currently sitting on the first trimester, which is why, and since you spoke about it, I just took you here. Now we'll go back to our this thing Viva on first trimester, and then what you do. You've done an OGG test in her booking visit and it is normal, which is why I was asking you that why exactly have you done her OGGT right now? All right. What about second trimester? Everything was okay?
Yes, ma'am. In her second trimester, quickening felt at 5 months and 2 doses of tetanus toxoid she received. And she is in regular follow-up visit with regular BP monitoring also in each visit. And at 4 months of amenorrhea, she underwent this oral glucose test. And it was deranged as per the patient and advised for diet control. And the ultrasound anomaly scan was also done and it was said to be normal. And no complaint of shortness of breath, weakness, and easy fatigability.
All right. So now you tell me, Lavanya, we have this patient now whose OGGT came out to be deranged. All right. And then she was put on diet control. So she was not given any drug for her sugars?
No, ma'am. So first I want to try giving counseling her, and I want to tell her to be on diet control, medical nutrition therapy. And later on, I'll, depending on her sugars, I'll tell her the further plan of care. So medical nutrition therapy, I advised her for 2 weeks.
So what was of course, you might not be able to tell me exactly how much was her sugar, but can you tell my students what sugar value should directly put her on insulin, what sugar value should put her under, medical nutritional therapy, and what sugars do we need to put on, metformin or a drug of the equal category?
So, ma'am, according to DIPSI, if more than equal to 140, then we'll start her on medical nutrition therapy for 2 weeks. And later on, I'll ask her, and later on, I'll do fasting and postprandial sugars, which is fasting and 2 hours postprandial sugar. So, according to those values, I'll, if it is deranged, like if fasting sugar is more than 95 and postprandial is more than 120, more than or equal to 120, then I'll put her either in metformin or on insulin.
Lavanya, am I putting the right slide for you?
Which one is yes, ma'am. This is the one. Yes.
So this is the one, this is telling us about 2 hours postprandial. If it's less than 120, then you continue. This is when? This is after you've given her, okay, this is after you've given her medical nutrition therapy for 2 weeks, right? Yes, and why did you give her, that means, what do you want to say? If her, suppose her let's say OGD came out to be 180. Okay, 180. It is more than 140. So if it come out to be 180, would you put her on medical nutrition therapy?